stage mediastinum and what is the role of PET and MRI in early stage NSCLC. Now let's move on to management. So point of discussion in this talk will be, why are we preferring surgery? And suppose we prefer surgery, what will be the approach? Are we going with MIS, that is VATS or robotic, or we are preferring thoracotomy? What should be the extent of parenchymal resection? Lobectomy or sublobar, that is segmentectomy or wedge resection? How do we address nodes, that is systematic mediastinal lymph node dissection or just a sampling? Suppose we are doing surgery, is it associated with a significant post-operative complications? And what after surgery? Only surgery, or do we need to add something to surgery? I think Devyani has already covered what is early stage NSCLC. It is stage 1 and 2. But if you see ESMO, it says resectable lung cancer. That is, it includes some select group of stage 3A also. And coming to why we are saying surgery, if you see a paper published in 2006 by International Early Lung Cancer Action Project, they said that if you diagnose a lung cancer in stage 1 and operate within 1 month of diagnosis, 10-year overall survival is 92%. Now, coming ahead, we have AJCC 8th edition, which had a 35 databases. And what they showed that if there is a pathological T1, the 5-year survival rate is around 90%. If it is T2, again, it is somewhere around 70%. So what we can say from this, that surgery is giving an excellent outcome. And so are the recommendation. NCCN prefers surgery. Same is with ESMO and ISLC. Suppose now we have decided to operate. What should be our approach? So now I have shown two pictures, one on the right and the left. Left one is a normal posterolateral thoracotomy. It's a big incision. We are going to spread rib. Sometimes there is a rib fracture also. And obviously picture itself is a little bit horrifying and associated with much pain. Whereas on the right side, it's a smaller incision and maybe less pain that we'll see in the coming slides. We have various evidences which supports VATS as far as short-term outcomes are concerned. It is associated with less pain, faster recovery, less of a perioperative complication, better quality of life, overall reduced cost also, and with equivalent oncological outcomes. To support this, there are meta-analysis which says that morbidity profile is better with minimally invasive. Oncological outcomes are either better or almost same. Same RCTs, 2016 and 2018, they all showed that there is a decreased procedure time, blood loss, there is less of analgesia requirement, it is cost effective and associated with less or similar complications. Now, in 2022, we had a very important randomized control trial that came up, that is Violet trial. This again had randomized patient into open versus open versus VATS lobectomy. And what they found that quality of life was better for 6 months after surgery. And after that, there was no significant difference. Even pain score was better on post-operative day 2 and with significant less analgesia intake in a minimally invasive approach. And so is the global trend. If you see a Society of Thoracic Surgeons database, out of 27,000 lobectomy or lung resection, 62% were by VATS approach. So VATS is preferred. Now we have decided surgery also, approach also, but now coming to a parenchymal resection. This is an old paper published in 1995 by Lung Cancer Study Group that standardized lobectomy. What they showed that if there is a sublobar resection, that is wedge or segmentectomy, those group of patients have increased chances of local recurrence. They have increased the chances of overall death as well as cancer-related mortality also. But this trial has few drawbacks. That is sublobar resection where mostly wedge. There was no adequate medicinal clearance also. So that's why we kept on searching for more and more evidences for sublobar resection. One of the RCT that had come up with only short-term outcome, published in 2018. Long-term outcome is soon to come. What they showed that short-term outcome, like complications following lobectomy or sublobar is almost the same, little bit more of an air leak in sublobar resection. This is another RCT published in 2022 where they had randomized more than 1,000 patients. What they found that segmentectomy patients had a better survival. And they were also looking at the PFT improvement. They found that there was an improvement in PFT, but not to the extent they expected. They were expecting around 10% difference in PFT, but they found only 3.5%. Progression-free survival were same in both group, but local recurrences were higher in segmentectomy group compared to lobectomy. So with all available evidences, what we can say that we have little bit evidence supporting segmentectomy for only tumors which are less than 2 centimeter and N0. But one thing to note that all segmentectomies are not a simple or straightforward segmentectomy. When we are doing lobectomy, God has provided natural fissure. We can go and dissect along those fissure. But when you are doing segmentectomy, we do not have that comfort. We have to transect parenchyma, which can be challenging sometimes. Some of the segment like 6 or 1 are simple, but 8 or 9 segmentectomies may be a little more difficult than the rest. And obviously there is a more of an air leak. So still we can say that lobectomy is what is preferred. Now let's come to node. We have nodal sampling or dissection. We have 5 important RCTs. They had plus or minus outcomes, but if we analyze as a meta-analysis, which was published by Mokels in 2017, it says that SMLND, that is dissection, has little bit trend towards better improvement, and it can prognosticate disease more compared to sampling. Sampling is what you see that nodal group, you dissect and find out if there is any significant node, you sample or remove that. Whereas a dissection is a template. We clear complete subcarinal and the ipsilateral paratracheal nodes. So it says that dissection had no significant morbidity compared to sampling, but it can prognosticate disease better and little bit trend towards better outcome. Now let's see, we have operated patient. Is it fine that like surgery is, what are the complications associated with surgery? So one, the trial that I have shown on the left hand side, that was published in 2011, that is same by Gail Darling, Ecosog Z0030. There, it had more than 1,000 patients and 93% were open surgery. What they found that mortality, perioperative mortality was 1.37% with morbidity of 38. This is all morbidity. Whereas on the right hand side, that this is JCOG 0802 published in 2022, where most of the surgeries were VATS, that is 90%. They had a mortality, 90-day mortality 0% and major morbidity of 26%. So from 2011 to 2022, we have kind of decreased morbidity and mortality also. What is our data? We have analyzed our uniportal VATS surgeries and we found that median hospital stay is only 4 days. Postoperative mortality, that is only 1 patient had died because of pulmonary complication, that's 0.9%. And morbidity is also manageable, that is 13.2%. Now we have operated. Should we stop there? As the stage increases, outcomes worsens. As the T stage or N stage increases, 5-year survival goes down. So do we need to add something? So if you see patients who has undergone surgery for early stage lung cancer, 50% of them are going to recur or going to have some or other sort of disease within 5 years. LACE meta-analysis shows that there is 5.4% OS benefit, around 5.8 or 9% DFS benefit also with system platinum-based chemotherapy. And it is more if the stage is higher. That is stage 2 and 3 had a better hazard ratio compared to stage 1. But do we stop there? No, I think we are still struggling and searching for more and more evidences to decrease that disease disease recurrence. So this is a Checkmate 816 where they added immunotherapy, that is nivolumab with chemotherapy compared to chemotherapy alone. They found a significant DFS benefit with immunotherapy, and also PCR rates were high, 24% versus 2%. And what they found that the patients who have achieved PCR had 85 or 90% less chances of having any kind of disease or mortality because of the lung cancer. I think this needs no explanation. Adura trial in EGFR positive patient, it has shown a significant DFS benefit. So at the end, I would like to conclude by saying that surgery is still the standard of care for early stage NSCLC if patient is medically fit. VATS should be preferred, but if you are not well versed, open thoracotomy and R0 resection, that is oncological completeness, is more important. Lobectomy with lymph node dissection is preferred, but obviously unmet need still persists, and we are still searching to improve that DFS and OS. Thank you. If there is anything anybody wants to ask, happy to answer. Thank you.